All right. So we wanted to spend a whole hour on this in the course because it seems to be one of the most novelly important factors, one of the most novelly uh, emergent pathologies which has arisen as the result of this pandemic. And what's really fascinating is that when we start looking at other respiratory viruses, including the flu, which we're going to do next week, we see very similar effects. So, and I don't think there was this degree of attention put on that prior to the COVID-19 pandemic. So, whether or not this is unique to COVID, it does seem to be something that we haven't, as a society, put a lot of attention on until now. And I actually don't think it's unique. I think there was, we'll see in some of the papers, they talk about this, and the papers were published before COVID, where they were seeing a lot of this uh, same sort of clotting, endothelialitis. Obviously, maybe not the renin and angiotensin system being involved. That seems to be particular to this disease itself. And I think that that last point is actually what probably makes COVID a more egregious infection than some of the other typical coronaviruses that you've been exposed to throughout your life, is that it's actually interacting with a protein that is vital to your blood vessel function, in particular to the integrity of your pulmonary vasculature and to the integrity of your blood pressure system, which, as it turns out, we're going to get into it. But if you can't keep your blood pressure appropriate, you can't keep your lungs functioning properly as a result of that. And so it's sort of this feedback loop that gets out of control, and you end up with real problems. So, let's see. Should we start with this paper and then bounce over to the slides? Oh, okay, you got the slide.
Yeah, I basically so this first slide is an overview of the system as we're talking about it. So it's the renin angiotensin aldosterone system. And like most biological networks, it is a network of biofeedback. And so before we get to the paper and we start getting into the details of the way that it breaks, I figured that we should look over it and we should understand what the system actually is. So basically, it is centered on a couple of hormones that are produced
So
in.
real quick, the goal of this system is to maintain your blood pressure, right?
Yes.
And this is important because your blood pressure needs to change depending on different activities that you're doing. If you're lying down taking a nap, you're going to need to have a different blood pressure than if you're up and running around. And you're going to have a different blood pressure then versus if you, let's say, fall off your bike and cut your leg open and you're bleeding all over the place. You need to have a different blood pressure in that condition. So it needs to be a dynamic system that has feedback and amplification. And that's how we end up with such a messy chart, essentially.
Exactly. And so it starts with the production of this compound called angiotensinogen by the liver. And angiotensinogen is basically a compound that circulates in the blood. It is produced sort of as a baseline factor as part of the blood plasma. And then when you have a decrease in renal perfusion, which is at the juxtaglomerular apparatus, which is the cells that are just outside of the glomerulus of the kidney. The glomerulus, if you remember, is basically the place where you have a little cluster of capillaries and it acts as this filtration unit for the blood. So all of the blood passes through the glomerulus in order to be able to be filtered into the kidney and then excreted as urine. And so you have these sensors here that are able to say that, like, whoa, hey, we have suddenly received a decrease in blood flow. And when that happens, it's actually the adrenal cortex which produces this a compound called renin. And where is it? No, it's the kidney. The kidney produces the renin. And so the renin is secreted by the kidney, and it is able to cleave angiotensinogen into angiotensin 1. And angiotensin 1 is a precursor molecule, which means that we have not yet gotten to the point where we are actually at the molecule that's going to be doing everything that's downstream. You first have to cleave your angiotensin using angiotensin converting enzyme, ACE, into angiotensin 2. Now, angiotensin 2 is the actual active molecule throughout the body. And so as your levels of angiotensin 2 increase, because your kidneys have started to produce renin, because they're like, hey, we don't have enough blood flow going on here. Something is wrong. Angiotensin converting enzyme makes more angiotensin 2, and angiotensin 2 has global effects on the body. It's going to increase sympathetic activity, which is this fight or flight response, which causes blood vessels to constrict. You have to be ready to act. You have to be ready in motion. And so it's going to act to try to increase blood pressure, because as soon as your vessels are constricted, you're going to get the immediate feedback loop back to the glomerulus that all of a sudden your blood pressure has increased, and then the system can start to equilibrate. You're also going to start to change your salt concentration. So you're going to change how sodium is reabsorbed into the blood. You're going to release more potassium. You're going to retain more water. Retaining the water increases your vascular volume, which means that if you have more volume, you have higher blood pressure. I think that the sodium and the chloride are important for two reasons. One is that you have osmotic pull, where if you have a lot more salt that's retained inside your bloodstream, you're also going to retain more water. But I have a feeling that this also has an effect on signaling. Action potentials are sodium-potassium based, and so if you can tweak the concentration of sodium in the body to put it into a more sympathetic state, you can have more likelihood of an excitatory signaling potential. And so in addition to increasing blood volume, it is also creating conditions where you're going to be able to react in order to deal with whatever situation you're in. The adrenal cortex gland, which sits on top of the kidneys, produces aldosterone, and we'll talk on the next slide how aldosterone feeds back into this entire system, but it's also a positive regulator where it is basically enforcing the system to run stronger and to keep pushing blood pressure up and up and up. Angiotensin is a direct vasoconstrictor because it binds to receptors inside of all of your arterioles or your capillaries, causing them to constrict to increase blood pressure. And then you also have that it acts on the pituitary gland in order to release hormones that are going to cause more water to be reabsorbed into the blood, all of which leads to an increase in water and salt retention. The effective volume of the blood increases. You all of a sudden have normal blood pressure, and this feeds back onto the kidney, and the kidney is like, oh, thank God. Okay, we can turn off the renin. Everything's okay. And then the body has basically hit its stride again.
Yeah, so the only thing I want to point out on here is that all of this is facilitated by ACE here.
Mm-hmm.
Right? None of these productive effects are going to happen without the cooperation of a functional ACE enzyme. ACE2 is essentially an analog of that, so it's doing the same thing. And that's going to start to make sense in terms of the pathology when we start looking at the COVID patients here in a second.
Next slide has a little bit more detail about what's happening at the kidney, which is that you basically...
And this matters a lot because these are the things that are breaking down when your ACE system is not working, which is what we're seeing in the COVID patients. So when Dr. Benneberg is going through all of this, you can think like these are the things that aren't going to work out for you if you have interference with the activation of this system. Because
it would seem that spike protein interacting with this angiotensin converting enzyme, because we talk about the ACE2 receptor, but it's a receptor, but it's also it's an enzyme. It's changing angiotensin 1 into angiotensin 2. And so if you don't have your ACE receptors around, then you can't undergo this transformation. And this creates a really, really inflammatory state because angiotensin 1 is actually a very pro-inflammatory condition. So if you have high levels of angiotensin 1 that you're not able to convert to angiotensin 2, your body is basically stuck in this very, very reactive, damaging condition. And so when you have something that binds, when the spike protein binds the angiotensin converting enzyme receptors, what happens is that they become endocytosed. And so it causes the amount of ACE2 receptors to decrease. And so that forces your body to maintain a higher level of angiotensin 1, which appears to be contributing to all of the problems that we're seeing in people.
Yep, that's the main point for the entire lecture today. So if you don't learn anything else, hopefully this begins to make sense.
Oops.
And okay, well, we'll get into that. We need to think about what having a dysfunctional renin angiotensin system, what's that going to physiologically do to your lungs and to your other tissue, but we'll get there. Obviously, we all know that high blood pressure is a problem, but maybe it's not totally obvious why.
So you basically have this angiotensin 2, which is converted into angiotensin 1 through 7, which is basically a shorter form of angiotensin 2. And it's happening at the exact same place as these SARS-CoV-2 virions are getting into the cell. So we have a bunch of different players here. Forgive the sort of the mess of this, but you have one pathway where angiotensin 2 is absorbed through the angiotensin receptor, brought into the cell, activates calcium signaling, which causes vasoconstriction. Then you have this relaxing form where if you can convert your angiotensin 2 into this shorter form of angiotensin, then you activate a different signaling pathway, which allows for the release of the constriction that was activated by the molecule before it was cleaved. We'll talk in more detail about these serine proteases, and ADAM17 comes up in the paper a little bit. And so we'll wait until we get to the paper in order to really discuss this. But these are very deeply related systems that at least some of the pathology is caused by the fact that you are downregulating ACE2 and upregulating ADAM17, which is leading to this very pro-inflammatory condition where you're producing and secreting many, many more pro-inflammatory cytokines than you are sort of allowing the immune system to return to a baseline. We'll kind of talk about this in greater detail as well as we get farther down. Maybe we can come back to this once we look at the paper. I think that would be smarter.
Sure, yeah.
The molecular...
the renin angiotensin system is like this, I think it's like the second part of the paper anyways.
Mm-hmm.
I also pulled some animations too of this stuff, which might be worth watching.
Yeah, exactly. We can come back to it after we look at the animations if we need to.
Or yeah, I don't know.
Or not at all.
Or not. Or we don't even do the animations. I don't know. So the paper starts off and it is basically reviewing some of the stuff we did the first week.
Right, so this is actually a very generic format of a science paper. No matter what kind of science paper you're going to write, the first section of the science paper is always the same content, and it's basically just a collection of statements of fact. Like, this is the background of this disease, this is why it is important to study this disease, this is what is known about this disease, and this is what is unknown about this disease, and this is what we're going to talk about in this paper. And it's basically every single science paper works that way. And this one is absolutely no exception.
And they each sort of they each have their own slight take on what they think the main problem is here. This paper starts off and it seems like they basically say that the main problem here is age, which is kind of interesting right out of the gate. I think one of the papers we had earlier said that the main problem was obesity or something like this. They each sort of have their own take on it. And none of them are right or wrong. It's just none of them are wrong anyways. These are all important contributions, but they start off by basically reminding us that COVID, they start off talking about deaths, right? Case fatality rate is almost non-existent in children, very low in adults up to 50 years, but rises exponentially from 1% in patients between 50 and 60 to more than 20% in patients over 80. You want to just show that figure really quick? Yeah, there we go. So there you have it. They want us to focus on the fact, I think what they're doing is they're building a thesis to the point that, hey, heart problems are what kill most people on Earth. Heart problems don't seem to appear until after 45 in the general population, And COVID seems to be exacerbating those problems, which are essentially the background stuff that's killing us. Um,
There's something very interesting in this mortality data where when you look at the distribution of age groups and who the pandemic is dangerous to, China's a pretty significant outlier in the way that the data is presented, and I haven't found a really clear explanation of why that is the case. I have found a lot of think pieces about places like Russia and India and China not necessarily reporting their COVID statistics accurately. Like I know for a fact that there was an article that was talking about how they think that maybe COVID deaths in India are 10 times higher than what's been reported. Russia's barely reporting any COVID statistics whatsoever. And obviously, like the statistics for all of these other countries are just what people are reporting rather than what is actually happening. And so there's some kind of filter that everything is passing through.
Or if you even take them at face value, there have been completely different procedures in place in China than in essentially the rest of the world. So,
Yeah,
who
that's
knows
definitely
what's
true
happening? Maybe I don't even want to speculate. I'll just get myself in trouble. But this is crazy. Like these, if you take these at face value, a lot more young people are. Well, I don't know if they're considered young, but younger elderly people between the ages of 60 and 70 are dying in China versus in the general population.
I mean, even between 40 and 49, right? Like you have in Italy, Spain, Netherlands, and the UK, when you're like between 40 and 49, you're at this point of the graph. I mean,
Right? Exactly. That's the thing is when you look at the graph overall, it's like everybody's reporting essentially the same trend. Most people who are dying are in the upper half of their life when they're succumbing to cardiovascular issues. I think this might be a good point to jump over and look at the background extinction rate for the population in general. So we'll just skip all this right now. Okay. So this was the best data I could find. It's a pretty massive Lancet study that looked at all like 131 countries between 1990 and 2013. And folks tend to die after the age of 45 in general, anyways. A lot of these deaths before 45, when you start to scrutinize in this paper, they come from accidents. So young people are mostly dying from accidents, anyways.
and poisonings, weirdly enough. Poisonings.
And poisonings. Too. Yeah, that's interesting.
So they eat opioid overdoses and prescription drug deaths are all
kids like the drugs. That's what it is. So, anyways, I think that it's important to keep in mind that the thesis of this paper seems to be that COVID is exacerbating this background cardiovascular pathology, which is rampant in the population in general, particularly in the developed world. But of course, people in the undeveloped world are dying from, completely different things at younger ages as well. All right, so back to the paper. I just jump over.
No, just one.
I'll learn this eventually. Okay, cool. So they're setting up the case for us of what they think is going on with this virus, which seems to boil down to it's making things worse that are already a problem, and we should deal with those problems. All right, so this is they start elaborating. They start over here elaborating when the virus was first identified in Italy, and they point out that interestingly there was all of these clusters of comorbidities which were apparent, which feeds into these seem to be also sort of the things which are contributing to death in the background population, such as hypertension, arterial hypertension in particular, which is going to affect the pulmonary system. Diabetes type 2, which is which is associated with obesity. Atrial fibrillation, which is an interesting one. We'll talk about it. Chronic renal failure and chronic obstructive lung disease. So I made some slides for those. I don't know if it's worth the time right now, though.
I mean,
do we understand what all these are? Yeah.
They are all ways in which the cardiovascular system is demonstratively dysfunctional. In the case of diabetes, it's also the fact that the actual blood vessels themselves can likely be damaged, because you're talking about a situation in which you have high levels of circulating glucose, which is dangerous on two levels. Number one, glucose can crystallize in the blood, and the actual glucose crystals can cause damage to the vasculature. And number two, you have high levels of sugar in the blood, which are causing changes in osmotic pressure. They can cause changes in the rate at which bacteria can grow. There's lots of negative outcomes from having even just one of these conditions. If you have 3 or more comorbidities, that means that you have these things layering onto each other, which makes it pretty apparent why a virus that messes with your angiotensin system can have such strong negative effects on the body. And it also makes sense that of why people that are young are not dying from it at rates that are anywhere near the rates at which old people die, is because your cardiovascular system when you're young is generally pretty strong. Like we'll see that that's not always the case when it comes to like myocardial infarction rates and things like that, but even with...
Well, no, it is with myocardial infarction rates.
I was going to say, like, even with the elevated rates, you're still way below what you would be for somebody who's 80 years old.
Yeah, so there might be damage happening to young folks. We're going to look at that at the end of the paper. There might be damage happening to your cardiovascular system. The question is whether you can bounce back from it very quickly or not, and whether that's going to result in a long-term pathology for you. I mean, the heart's one of those things that's largely ignored. When you're young, you're like, it doesn't kill young people for the most part. Like, these diseases take years of abuse to add up, but at the end of the day, cardiovascular complications kill most people. Without a doubt, they will, without knowing anything about you, they will probably kill you. And so it's really worth considering what you can do when you're young to avoid that fate when you're older. At least prolong your healthy life as long as possible. Obviously, no one's going to live forever. Something's got to take you out eventually. But, and I actually really, really respected this article because they ended the article, not to give away the, what is it, spoiler alert?
Mm-hmm.
Spoiler alert, they end the article with, hey, if you want to advise the public on what to do about something like this, a good dose of exercise will get you a long way further than anything else that's on the table. I thought that was really salient. But anyways, we're not there yet. We'll get there.
Yeah, so here this is basically continuing kind of giving the outline of who it is vulnerable. And so you see that, for example, death from COVID-19 was strongly associated with male sex. There was another study that I saw the other day, which was looking at heart problems after COVID, and it was looking at in an older population. It was looking at the VA hospital. And there it was kind of astounding because as far as I could tell off the data, it was like a 2x risk for men over women at a certain age. And that's not totally clear. At the beginning of the pandemic, there was all sorts of possible explanations. People were like, well, men are more stressed than women, which arguably you could make the case for, because if you look at the conditions, like if you look at things like life expectancy, college enrollment, lifetime success rates, like being able to read, how often people are committing suicide, men are doing worse than women at all of those. And so you could very sort of superficially look at that and be like, well, men do seem like they're having a harder time in society than women are for whatever reason. Whether that's because women have stronger social networks and are able to manage their sorts of stresses better, or if it's because we're living through the era where women's rights are finally becoming centered and we have no ability to create a world where centering rights of one group doesn't mean that we're disparaging the rights of another group. I don't know. But the point is that you could make the case that men suffer more in some ways. There was also that it appeared that smoking was a pretty significant risk factor as well, and men tend to smoke more. And so it could be something about lifestyle, it could be something about protein expression, it could be something about the interaction between gender and society. It could be all of the above, but it does seem that male sex is definitely a predictor for the worse. Old age is the worst comorbidity to have. This is why literally Silicon Valley has decided that it is obsessed with ending death, because death comes when things stop working, right? And so as you get older and you approach the end, what means is that all of your systems are no longer firing effectively. We talk about immune senescence a little bit during this paper. And what that is it's basically the fact that the immune system just kind of stops. It just gets tired.
Yeah, it's an unfortunate thing that's difficult for humans to cope with.
Mm-hmm.
That the beings aren't sort of set up to go on forever.
What's interesting here is that they say that in contrast with earlier studies, arterial hypertension was after adjustment for age not an independent risk factor for COVID-19 hospital death. And so,
what that means to me is that it's not the hypertension itself so much as that hypertension is associated with other stuff that's going to kill you.
Yeah. Including
age. That's what they say.
And it's really interesting to look at something which appears to kill people mostly as they become sicker and sicker, because you really, it's this like quantum thing again, where you look really, really closely at what's happening and you realize that it is not as it's
just not as clear cut as what it might look like from like a way above it.
Yeah, like the more that I read these papers, the more I'm just like, well, yeah, old people get sick and they have to die of something, and so it makes sense that COVID-19 is this destructive thing that is killing them. And it's very, very hard to look at that and to be like, well, this is unexpected.
Doesn't make it less painful.
It doesn't make it any less painful.
Nobody wants to lose grandma.
Yeah.
But it's it does start to make sense, as sad as it is. Let's say one more thing about that.
In summary, although advanced age is the strongest predictor of mortality related to an infection with COVID-19, there is extensive evidence from reports on the COVID-19 pandemic that diabetes and pre-existing cardiovascular diseases are independent major risk factors for hospitalization at ICU and mortality. Many of these comorbidities are linked to obesity and the related impairment of metabolic and cardiovascular physiology. So basically, if you're old, that's your highest risk factor. And then beyond that, you also have all of these other problems that have to do with this renin angiotensin system, which is what this paper is basically going to be about. I know that you have a bunch of slides about this pulmonary stuff. Do you want to go back and look at it?
So, yeah, well, they have a figure about it. Maybe it's best to just go through the figure, because I tend to make more slides than we'll need. I don't want to confuse the matter anymore. The reason, well, maybe we'll have to do it, though, because their main scoring system is this PEEP thing, which is very difficult to understand without a picture of it.
Mm-hmm, mm-hmm.
So let's see what this test is about. Let me see if I can summarize it really quickly first. Maybe not.
I mean, before you switch over, there's basically two conditions for COVID. There's this L phenotype, and then there's this H phenotype. The L phenotype is the less severe phenotype. The H phenotype is the more severe phenotype. And the way that they characterize these are scored as basically a factor of just once. It's in Brave. Yeah. These are basically scored as a factor of what we're going to show right now on the screen.
Yeah, so these are essentially two stages of pneumonia, and they matter a lot to the folks in healthcare, because if you enter into one of these forms, you're very likely to start, on ventilation, you're going to start damaging the lungs. I think that's why they're so concerned with that in this paper, which is seems to be a clinical advisory.
So L-type are patients that are basically, they're breathing more or less okay. Their partial oxygen pressures are are still in the oxygenated region. If you do a chest scan, what you see in figure A here is the fact that you have a pretty well aerated lung. You might have some areas that are starting to become dysfunctional. Like you can see a little bit of strangeness up here at the top left. But generally you have this like very dense, healthy lung tissue that has not become filled with fluid. By the time that you get to H-type conditions,
and the lungs at this point are becoming kind of stiff and unwilling to expand, right? So when you push air into them, you're actually going to start cracking them open.
Fibrosis.
Right. You've gotten scarring, exactly. So the fibrosis is essentially a scarring feature, which I think we have some slides on that too in a minute. And so you're going to actually start doing damage to it at this point. I think I might have had
You have another slide on this, yeah, but like, yeah.
Okay, this is kind of nice too.
So they talk about lung recruitment, and they talk about the sort of the difference in recruitment. And so do you want to kind of walk through this?
Yeah, this is a little confusing. 1 second.
You can just minimize it by pressing this guy.
So when they say there's a potentially recruitable lung, what they mean is that there's alveoli. Does everybody know what these are? Maybe we should mention. These are the little air sacs in your lungs, right? Where the gas exchange is happening. You have these little furry epithelial cells that have a ton of surface area. Nice. This is a gentleman who's been smoking a little too much. Yes, they should look a little bit like more on the side on the left than on the one on the right. But as that tissue gets damaged, it breaks down. It becomes fibrous eventually. But essentially, the essential feature is that it becomes this open bag like that, right? And it becomes a sort of dead space that's not actually filling up with air when you're breathing in. So the patient's normally breathing. There's these open holes. They're not. I think the blues essentially represent where gas exchange or where air is reaching, not necessarily where gas exchange, but where the air is coming into the lungs. So these patients have a bunch of, they call it dead space. It's dysfunctional tissue inside the lungs that's just sitting there. And the problem is that you start pumping air into that dead space under ventilation, and you get into serious problems later down the road.
Right, like there's supposed to be I think that this
which is called recruitment.
Figure shows really nicely here, where you do not want the alveoli to collapse too much, because what happens is that if by the time that you expire, the walls of the alveoli collapse in on themselves because they don't have the sort of necessary elasto-rigidity to stay open even as you breathe out, and they just kind of like flaccidly collapse, you end up in a situation where, think about having to blow a balloon up, right? So you have this latex balloon, and the first blow is the hardest because you're basically having to push past this material resistance. And then once you're past the material resistance, it's much easier and you can blow the balloon up. Like you see little kids do this all the time when they're trying to make water balloons, right? Where they're just like, I can't do it. And so a grown-up has to start it for them and then they can finish it. And so you have to be able to maintain the flexibility and the strength of these alveoli, because if you don't, then you end up in a situation where you have these flaccid sacs, and then if you are trying to push air into those and they're not responding appropriately, this is the kind of stuff that you'll rip. Basically, alveoli that are already damaged, and you have to put so much force into them in order to reopen them that they just burst.
And it's not clear that they're doing very productive gas exchange in the first place either.
The alveoli?
Those collapsed ones, yeah, exactly. Because they tend to be those sort of disorderly, fibrous. They're scarry to begin with, right? Because they've been damaged in the other part of your life. You know, smoking is not the only way you can damage your lungs too. It's a real big problem in underdeveloped parts of the world, even out in the country in the developed world where there's tons of smoke everywhere. This is, by various estimates, an extraordinarily dangerous contributor to public health outcomes.
I mean, you can also work in a factory where there's a lot of particulate matter in the air. This is why things like OSHA are really important, because if you have somebody that goes to work day in and day out and they're working in a garment factory and there's lots of particulate matter in the air, that stuff settles in the lungs, and over time it can cause either, I don't necessarily think that it can cause emphysema, because I think that actually is defined as being a smoker's disorder, but it
Well, it's
can
fascinating
cause
because
ARDS like pulmonary edema, which is basically emphysema by any other name, I think.
I was gonna say, I think emphysema also is synonymous with another term. I don't think it's.
Just once.
Where is it? I think this one of the first ones that I listed. There, chronic obstructive lung disease is what they call it in the paper, which is synonymous with emphysema. I thought that was kind of fascinating. So this phenotype of these essentially worthless alveoli is common to a whole range of injuries that can occur essentially long term over the course of someone's lifetime.
Mm-hmm.
Cool. So that is the transition. This is a really clunky figure. I'm not super proud of this one. I really like the first figure. This one's very difficult to parse, but what they're trying to speak to, I think, the healthcare practitioners in terms of making choices about when and when not to put folks on ventilation, because this hasn't been a problem in a year or two or since it all first broke out, but there is some evidence that a lot of patients who were not prime candidates for ventilation were being put on ventilation when perhaps they should have been treated with other vasodilating therapies instead. And so I think this paper is when did this paper come out? 2020?
And they're saying that there's a transition between the two different conditions that can happen for a number of reasons, right? So here, and they're showing basically that you go from this L phenotype to this H phenotype by way of either an expanding viral infection, which makes sense because you're basically you're recruiting more immune cells to the lung area. You can have this pulmonary microthrombosis, which also makes sense because the H phenotype is the phenotype in which you're starting to get fibrosis and edema, which means that your liquid is filling the lungs. And so when they say that you have this high lung weight, it's basically the fact that instead of being filled with air, your lungs are slowly starting to fill with liquid. Higher recruitability, this high right-left shunt. Did you catch that?
Yeah, that's kind of interesting. So a right-left shunt is a situation where your right to left ventricle, there's blood passing from your right to left ventricle without going to the lungs first. So if you think about that for just a second, I think I have a picture of it actually, because it kind of blows your mind because you're like, how does that happen? No. There we go. No. There we go.
Mm-hmm.
The case that's usually made is that there's a ventricular septal defect, which literally means that the wall between your right and left ventricles is broken down. That's crazy. But it seems to be fairly prevalent in people that are suffering from this advanced form of COVID.
I've actually heard that septal defects in the heart are not that uncommon.
Okay.
Which is, I don't totally know what the prevalence in the population is, but I do remember my mom gets really bad migraines.
Well, it makes sense.
Hmm?
Sorry, I didn't interrupt you, but it does make sense.
But my mom gets really bad migraines. My mom gets really bad migraines, and I was looking at experimental treatments, and at some point I discovered that there was some treatment that they were doing where they were closing this septal defect in people, and it was curing their migraines, which is...
That's crazy.
I don't necessarily know what the prevalence of it is, but there does seem to be some kind of either electrical or otherwise connection between the heart and the electrical storm in the brain that is the migraine. And so maybe it is more common than I thought. Did you look at it?
Well, yeah, I was just thinking about it too. In development, you don't want to have your lungs connected to your heart. And so there's actually a shunt that's naturally there during development.
And so it just doesn't close.
Yeah, so it might just be a naturally weak point, just like your belly button, right? It's a naturally weak point in your musculature. Sort of similar thing. At least it can become at some point. I know herniations of the belly button are quite common and not even pathological. It's just a lot of people. If you got an Audi, you probably got a herniation.
Right, and I think that they're talking about a high right to left shunt. They're not
Exactly.
talking about the fact that it suddenly appears,
Right,
which
right.
means that there must be some fraction of it that is relatively common in the population. But all of these are basically going to be caused by lung injury, blood clots, cytokine storm, which will eventually lead to clots because it activates the complement cascade, which will cause clotting. And this is basically just an overview of the way in which these conditions can affect partial oxygen concentration over time and what that means for the success of treatment. Like ECMO is your last ditch effort, and this is what was really hurting people. They were giving it too early, and so you were getting this sort of the ripping of the lungs. Right, so histologic examination of patients who died at the later stage, which is the H stage, shows acute fibrinous and organizing pneumatic lesions with extensive intraalveolar fibrin deposition, intraluminal loose connective tissue formation in the alveolar ducts and bronchioles, and moderate interstitial lymphocytic infiltrates, which basically means that you're having widespread breakdown of the alveoli. They're becoming filled with this fibrin. Connective tissue is basically like getting into the spaces where oxygen should be. It's an ugly, ugly, ugly situation. Let's see.
But I think we're gonna start talking about the ACE2 system, which we've already really launched. You know, one thing that, can we go into the ACE2? You ready?
Let's do it. Yeah.
All right. So, in addition to the overview that we've made of the ACE2 system, which I kind of feel like it's sufficient at this point, I had some animations, but I'll leave them in the presentation if anybody wants to watch them later. But they do mention that soluble ACE2 seems to be a thing, right? So it's almost like there's this, I imagine, has to do with loss of, like with endothelial shedding into the blood, right?
I had a slide about this. I'm looking for it.
Oh,
Checking.
cool. So
actually, I didn't have a slide for this. The paper has a figure about this. Let's go look at this. Okay. So these figures are a little insane, mostly for design issues, but they're actually quite straightforward, and they give a pretty good overview of what it is that we're looking at. So you have two conditions. You have a disease state and you have a healthy state.
Although I don't think that's the right way of looking at it totally. I think that it's more appropriate to look at it as in like a activated state versus like a baseline state, something like that. Because, you know, ultimately the renin angiotensin, especially the angiotensin 1 system, which they're calling sort of like bad news, it does a job. Like if you get stuck with a sword or something, like it's going to help you out. It's not necessarily there to ruin your life. It's just that when it gets, you know, permanently engaged or disengaged, engaged, yeah, you run into problems.
And I think that that's the point that they're making, which is the fact that the disease is that you cannot disengage it. The disease is because of the fact that you're missing this ACE2, which is necessary in order to shunt you into the protective condition. So what that means is that, okay, so you start with angiotensin 1, which we know is made by cleavage of angiotensinogen by renin that's secreted by the kidneys. And ACE is your angiotensin converting enzyme. It produces angiotensin 2. And so angiotensin 2, when it's taken up into the cells, is able to activate this very pro-inflammatory pathway, because what it's basically doing is a couple of things. So angiotensin 2 gets into the cells through this angiotensin receptor. It activates this cleavage factor called ADAM17 that lives on the membrane of the cells. And ADAM17 does a couple of things. Number one, it decreases your membrane-bound ACE2 receptor because it cleaves it, and now all of a sudden you have soluble ACE2 floating around in the blood, which means that you are no longer able to, in a location-dependent way, affect your angiotensin levels. Normally, things in the body are kind of controlled locally pretty effectively. And so if you have high levels of angiotensin 1 in one area of the body, you would have angiotensin converting enzyme there that's able to change it into angiotensin 2. But when ADAM17 cleaves that receptor and makes it into a soluble form, there's nothing holding it in place anymore, and it basically is just now gone. It's now a public good rather than a private good for the body. And that creates metabolic stress because the cell is like, well, I don't have any of these receptors. I have to make more of them. And so you end up in this kind of metabolic loop on some level. Then you also have that ADAM17 is also cleaving this TNF alpha. And the TNF alpha is able to interact with soluble IL-6, which is bound to the surface.
TNF alpha is a cytokine.
And IL-6 is also a cytokine.
So it's the siren.
And these two sirens, when they combine, are able to activate a secondary pathway inside of the cell through NF-kappa B, which we talked about before, which is basically the pro-inflammatory transcription factor of the entire immune system. Would you agree with that?
NF-kappa B, it's definitely like one of the top players. It's an
Yes.
MVP every
Yeah.
year.
And so NF-kappa B is then going to produce these massive quantities of inflammatory cytokines and ARDS, which is this acute respiratory distress syndrome. This all changes. So this is the pathway where you don't have ACE2, right? ADAM17 is cleaving ACE2. ACE2 is flying away. You don't have it anymore. This is going to lead to your vasoconstriction, your fibrosis, your inflammation, your oxidative stress. It's going to start destroying things here because it's going to start recruiting immune cells. Bad news bears. However, in a condition where you are able to re-equilibrate back to a healthy baseline, you have ACE2 around. ACE2 is able to cleave angiotensin 2 into a shorter protein, and so you lower the concentration of angiotensin 2, increase the concentration of angiotensin 1 through 7, right, at 1-7? I don't know. I've never heard that said out loud. And then
1
it gets...
through 7. There's several of them.
No, there's one. It's a 7-membrane polypeptide.
Oh, I see.
So that gets imported into the cell where it activates a different transcription pathway, but in this case, it is a soothing transcription pathway, which is able to kind of calm everything down. This protein is actually in other systems is associated with mitochondrial function, which I don't know if this is the case inside of the human body because I was looking at it in yeast, but it's interesting on the level of mitochondrial function and actually being able to produce the energy that you need in order to be able to activate the repair after you've been exposed to the inflammatory conditions that were there in the first place.
I had a sneaking suspicion, but I wanted to check it first. So NF-kappa B, I think the reason we see it everywhere is it was the first inflammatory transcription factor ever discovered, and it's the one we've been studying the longest. And that's like another thing that I hope you guys take away from this course in general is that we only see what we're looking for in science. And this is really important that we keep an open mind that we don't know a lot of things. And so
like you're saying that there's other ones, but
there almost certainly are. I can't say that for sure because we haven't seen them. That's my point, is that we don't know what we don't know. This is one of the hardest things about being a human is you never know what you don't know. You only know what you know. You know what other people know maybe, but you don't know what you don't know. And you gotta be careful of those because that's what gets you into these positions where you have overconfidence in any particular theory or whatever, you know. Anyway, sorry, that was a little bit of an aside. But you asked a really good question because we see NF-kappa B everywhere. You know, well, we see it because we've been looking at it for a really long time, so we're very good at characterizing it. I'm sure it's very important too.
We do have a tendency to see things that are important earlier than we see other stuff, just because they're the most visible ones. But visible doesn't always mean the most important. It just happens to mean that you can see it the best. You're absolutely right. That's a good point. But basically, to wrap up this figure, I think that we should wrap up this figure and take a break.
Okay. I'm good with that.
To wrap up this figure, the conditions in which you are protected by the presence of ACE2 is that ACE2 cleaves it into angiotensin 1,7. This gets imported into the cell, and you can see that the mechanism by which this is protective is it's not particularly clear. They're kind of looking at it and they're like, well, it's protective. It definitely leads to lower inflammation, but there's not a lot of details as to what this mechanism looks like here. In the case of the presence of SARS-CoV-2, you end up effectively getting a downregulation of your ACE2 receptors, so you get a decrease in angiotensin 1,7 because you're endocytosing the receptors with the virion after it binds. And so it's effectively leading you to this left-hand side where you're getting this inflammatory cascade that's being activated.
That's what I was going to say. So one of the biomarkers that was first detected associated with myocardial injury in COVID was this stuff called troponin. And I'm going to assume that you guys don't know anything about how muscles work, which might be a mistake. But essentially, this is. Let me see if I can show it. Actually, in your body, you have a good portion of your body is muscles, obviously. And muscles are composed of fibers, and the fibers are composed of even little fibrils. And what we're looking at here is a schematic representation of one of those little fibrils, a little piece of it, which is this repeat unit called a sarcomere. And essentially what you have is you have two different proteins. One's called actin, one's called myosin. And they interlock with one another. So there's long chains of each. And when you have a muscle contraction, you have this ratcheting effect, which is essentially illustrated here, where the myosin fiber has these little heads, and they kind of look like feet to me, but I guess they're heads. And the heads kind of pull backwards when the contraction occurs, and they ratchet, pulling on the actin like this. Okay, so one of the key players in that, one of the pieces which allows the myosin light chain to bind to the actin is called troponin. And the fact that they're finding this troponin floating around in the blood of these patients is interesting because you shouldn't have pieces of your muscles floating around in your blood, generally speaking. And so...
Asterisk. After you exercise intensely, you will have pieces of your muscles floating around in your blood.
I meant to look up the background rates of that.
Right. So, I mean, if you go work out, one of the things that you're going to be doing is that you are going to be damaging muscle cells, which will regrow and they will multiply, and so they will be stronger after they regrow. So, to some degree, troponin and creatine and myosin, these are things that after a particularly intense workout, you would expect to find in the blood. The question is how much and for what duration.
Yeah, exactly. And
What'd you find?
It's true. It's true.
What is?
Which exactly what you just said. So yeah, you do have troponin in your blood after you exercise, which, you know, I looked at the original paper that they made this claim about this troponin in the blood, and it wasn't clear to me that they had separated out the effects of exercise. So
I mean, okay, so let's look at the paper and see where this is actually. We're very disconnected.
Yes,
right
we are.
now.
Sorry.
Okay, so basically, what we have here, oops.
Let's talk about where they first report it.
Is that they are showing that
Here we go.
59% of patients that died displayed elevated troponin levels, as compared to only 1% of the survivors.
Data from China.
Then they looked at this in North America, where a huge number of the people who were studied were characterized by elevated troponin levels. And then basically when you have more and more troponin, they take that to be a readout of more significant myocardial injury, which then also increases mortality risk.
It
Makes
also
sense.
seems to be that increased troponin levels indicate that you are at risk for cardiovascular complications in the background population as well. So, sort of like selecting for age, we looked at age being a surrogate marker before. We might be selecting for the population that is predisposed to cardiovascular disease to begin with this. Or the virus is responsible for directly disturbing these tissues. And that case does not appear to be clear yet, although the authors seem to be open minded to it later.
Mm-hmm.
But they don't supply an actual mechanism if that is the case, which is kind of interesting.
Well, they basically say that it's inconclusive as to what is actually causing the injury. They're like, it could be that SARS-CoV-2 is infiltrating the cells and causing the cells to get damaged. Because when we talk about myocardial injury, we're talking about the injury to the heart muscles, right? So, and this was something that I was confused about for a long time because I thought that it had to do with blood vessels. Because we talk about endothelialitis, we talk about all of these different aspects of the blood, but what we're really talking about in this case specifically, myocardial infarction has to do with damage to the walls of the heart. And so in an earlier figure, when we were talking about higher than normal left to right transfer, that's basically about manifestation of this higher rate of cardiac injury. Because if you damage the wall between the left and right ventricle, then you're obviously going to have higher levels of troponin in the blood. If you are unable to effectively circulate blood, which means that you're not passing it effectively across the lymphoid system either, because this is all a fluid pressure system. The heart has to be able to move blood in one direction for lymph to be filtered properly through the lymphoid system, because fundamentally the heart is moving both the lymph and the blood. It's very hard to tease out the difference between lymph pressure and blood pressure. So if your heart is dysfunctional because there's a hole in it, your immune system is also going to be dysfunctional because your lymph isn't moving properly. And if your lymph isn't moving properly, then you can't clear out all of these fibrinogen plaques that are forming in the absence of the right kind of immune cells getting into the location where they can start to kind of quiet down the disaster that is happening.
You know, it's also worth mentioning that ACE2 expression is particularly high in the myocardial tissue as well. I'm trying to find an actual figure for that.
Right. And so there was also some studies about high rates of ACE2 expression in the kidneys too, right? Did you see that?
Yeah, that is true.
And in the early days of COVID, this was also something that was being reported pretty frequently, which is the fact that you can also have severe kidney damage from it. So here they say that there's a bunch of different mechanisms that could lead to cardiac injury, which include this microvascular damage because of the fact that you're throwing more clots than normal. Hypoxemia, which is different from hypoxia. Hypoxia is a decrease in oxygen concentration in the tissues. Hypoxemia is a decrease in oxygen concentration in the blood. And so what you're saying is that you're basically having a problem that's farther upstream.
So heart's at the top of the list after the colon and gallbladder, interestingly enough, for ACE2 expression.
That's really interesting. I remember reading about something about the gallbladder and COVID, but it kind of slipped through my mind. So yeah, they're basically saying that you have this prothrombotic milieu where you're throwing more clots because you have also hypoxemia, which is a decrease in oxygen concentration in the blood due to other critical illness. Obviously, people that have a greater injury. What did you look at the STEMI thing? ST elevating myocardial infarction.
No. Good question.
I'm gonna look that up.
Myocardial infarction is a heart attack, first of all. So an ischemic heart attack is where the blood supply is cut off to the heart. An ST elevating heart attack. What is ST? Figure that out.
It affects the lower chambers of the heart more strongly than a regular heart attack. And so basically it is just a heart attack that has more damage. When
More
we're talking about
involvement or something?
when we're talking about a non-coronary myocardial injury, what we're talking about is that it doesn't have to do with the
Well, the coronary artery is that which perfuses the heart, so it's not going to be an ischemic event. It's like your heart can break, your car can break for a number of reasons. They're not all the same. It doesn't. Sometimes the transmission goes. Sometimes the valve gaskets can rupture. Sometimes
is the heart
it's just out
the
of
car
gas.
in this example?
Heart is the engine. Yeah, it's the stuff under the hood. So we're looking at a situation where there's a lot of things that can break without the heart. I think what they're trying to say here is that there's something other than just ischemia is usually attributed to blockages, right?
And what they're saying is that those people that had a myocardial infarction that was based on blood-based mechanisms seemed to have a higher level of survival than those who were having heart attacks because of the fact that their hearts were damaged due to the problems with the muscle tissue itself.
So then they go on and they're like, well, we don't really know if it's the virus that's causing this or whether it's this cytokine storm, which is damaging the heart muscle itself.
They point out something that's really interesting, which is that very small study, 39 patients, and they showed that these patients had high viral loads, but they didn't show influx of immune cells. So basically these people that are dying have injury of the heart, high levels of the virion itself, SARS-CoV-2, but you're not getting the full immune response. And so what that seems to me to say is that you have micro damage that's occurring in the heart where the heart cells are getting broken down, and they're getting broken down sufficiently quickly that the immune system is blocked by the damage before it can get there. Do you know what I mean? Like, it seems to me that the damage is happening.
Yeah. That's certainly possible. It's also possible you're selecting for a population that has at least very damaged heart, and that's who you end up looking at because they're the ones who are suffering at the end of the day.
But you would expect them to have an inflammatory cell influx, because if they're just living with damage already,
might be also the same population whose immune system is dysregulated for other reasons.
That is possible.
Because of age and.
But what I'm saying is that the thing that prevents the immune system influx.
Yeah, where is it influx to, by the way? How do you?
We're looking at the heart.
Do you think that's what they mean?
Yeah. So they're basically they're looking at myocarditis, and so they're like, you can see virus in the muscle of the heart, but you're not seeing the presence of inflammatory cell influx. And so they're saying that viral entry is causing acute myocarditis because you're not getting the normal thing that we point to where we're like, oh, well, hey, look, it's the immune system that's causing all of this destruction. In this case, they're like, well, that doesn't totally hold because the cells that are in the heart have virus and they're damaged, but they don't have immune infiltration. And so, again, but they're also kind of like, we don't know what this means exactly.
Yeah, I think you're right.
And so basically, it's in this regard that it's of major interest that the myocardium is characterized by significant ACE2 expression, which means that if the virus is actually causing damage, what you would expect is that you could go to the other tissues that have high ACE2 expression, which is the gallbladder, which is the colon, which is the kidneys. And if it is an ACE2 mediated damage by viral entry, that you would then expect to see similar damage in these other organs, but perhaps it's not as deadly because obviously the colon, the gallbladder, and the kidneys are important, but I have this tendency to put the heart on the hierarchy where it's more important than the kidneys. Can you confirm or deny that?
Well, you can't live without either one. It's not clear from this paper to me. I want to say that they don't generally see infiltration of the immune system during myocarditis. I'm still trying to get to the bottom of that.
Okay, well, while Dr. DeLay gets to the bottom of that. This was very, very interesting too. We spent quite some time today talking about this, which is that, okay, you have a German cardiac MRI study that included unselected patients from a regional testing center that had recently recovered from a COVID-19 infection. And only a third of these patients needed hospitalization, right? So you have like a big cohort, a third of them need hospitalization. 78% of your patients, so more than just the third that required hospitalization, showed MRI evidence of cardiac involvement, and 60% had evidence of ongoing myocardial inflammation. So 3/4 showed some kind of effect of COVID on the heart, and almost 2/3 appeared to have extended inflammation, despite the fact that they were looking at this on average almost more than 2 months after the diagnosis of COVID had actually taken place, right? So we're 2 months out from the point that you have a positive PCR test, and in 78% of patients, you're still showing cardiac involvement, 60% of them show inflammation, and you can tell really, really high levels of, high sensitivity troponin T is going to be troponin T that is more difficult to detect, or it's going to be less difficult to detect?
I don't know the answer to that. I just want to follow up though and say that it does seem that immune infiltration is a feature of myocarditis.
Okay. So basically, they're
This
able
is
to
the study I was talking about where I wasn't clear if the exercise has been factored. Yeah.
Right, exactly. So let me finish the outline, and then we can talk about that. They 71 days after they had COVID, the body scan showed that the heart was still involved, and they're able to detect high levels of this troponin T, which is the breakdown of muscle, specifically of heart muscle, in the body. Then something that they say next is what really threw me for a loop, which is that cardiac findings on MRI were irrespective of pre-existing conditions. Okay, so you have an MRI that's showing heart problems, but it has no bearing on whether or not you have a pre-existing condition. It also, the severity of your COVID infection in the first place has no bearing on the severity of the MRI. And furthermore, the presence of cardiac symptoms has nothing to do with what they see in the MRI. And that is crazy, folks, because basically what they're saying is they're like, look, we're doing a diagnostic MRI, and under normal conditions, we would look at this MRI and we would say that this MRI is showing damage. So if you had somebody that came in and they were experiencing some kind of heart pain and you did this MRI on them, you would be like, well, look, obviously you're having pain because you have this inflammation. However, what in reality this seems to be implying is the fact that you have this pain, but it's not connected to the inflammation, because a lot of people that have inflammation detectable by scan don't have any symptoms. And this isn't the first place that I've seen this. There was a study a while ago where they looked at herniated discs. And so they did basically either CT or MRI of the spine. And they would show that in some not insignificant portion of the population, they would have what would look on the scan like a herniated disc. And they would report absolutely no physical symptoms, which opens the door to this conversation that we've been having about what does it mean to measure something. You're looking at a condition. Go ahead.
Or what does it say about back pain too? Because a lot of patients who come in with back pain don't have discernible radiological features either.
Yeah, it goes both ways. You can have pain.
Yeah, back pain is a really, if you guys want to go down a rabbit hole, it's a fascinating thing because most adults suffer from back pain and most adults can't find a reason for that. It's weird. Pain is a very fascinating thing because pain can be very real without there being an obvious injury, and it doesn't make it less of a problem if you've had it before.
What's weirder though is that even having the obvious injury doesn't seem to guarantee that you'll have pain.
Right.
That's the crazy thing. They're like, yo, we saw inflammation. We detected it molecularly, but they're not in pain and they're not having cardiac symptoms. What does that mean?
Well, the injury,
it's outside the realm of what they can even really offer.
Technically, when we go to the gym tomorrow, we're rip muscles in our bodies and have injuries, technically.
But this is a heart injury. Like, you shouldn't have like heart in on 60% of them had evidence of ongoing myocardial
I
inflammation.
understand, but when you look at this study, like they're comparing it to a different data set outside of the actual study itself, and it gets me wondering like how controlled it actually is in the end.
Well,
It needs to be taken with a grain of salt at least.
it does need to be taken with a grain of salt.
But
However,
yeah, it is fascinating.
even when you take it with a grain of salt, right? Even if this is normal, that 60% of people have inflammation on an MRI, that means that under normal conditions, people are walking around with inflammation that they can't feel. That's right. Because even if this is baseline, it's a really, really, really crazy thing. Do you know
But
what I mean?
but when you think about the fact that most people are going to die from some sort of cardiac event, it might make sense if 60% of the people are walking around with cardiac inflammation at all times. I mean, sugar is inflammatory, right? Like,
Specific
like
cardiac
baseline, wild, out of control baseline inflammation is the modern crisis.
This is true. We've had Dr. DeLay and I have had very intense arguments. A couple years ago, we were talking about something, and he was like, "You know what? I think all diseases are diseases of inflammation." And I was like, "How dare you say such a thing?" I was like, "You do not have the right." And as I've looked deeper and deeper into it, I've realized that that's the crisis of modernity, exactly as you said.
Yeah, it's very strange trying to keep a body together. I think we have to close down and end on this, but it's a very particular arrangement of gazillions of cells that all have their own agenda, and getting everybody to work together. If you've even tried to get a team to work together of 3 or 4 people, you're just talking about trying to do that at huge scales. I think we need to save time to take questions at this point, but I did want to read the last line of the paper, which I think is bold and wise. In this regard, we may not forget that apart from pharmacological interventions, physical exercise is one of the most potent antioxidant and anti-inflammatory stimulus at the level of the endothelium, with a proven effect on halting the aging-related endothelial dysfunction, apart from its beneficial effects on the classical cardiovascular risk factors. So there are all of these things, these clusters of symptoms that are going on, and this is almost rare for a paper to end with such a hopeful note. They're like, hey, this stuff's all pretty terrible, but there's something that we can do about it.
It's basically free.
And we don't have to even take any medicine. You don't need a doctor for it. And, when you're young, it doesn't really matter. But that'll wear off really quickly. And the trick, like, this is the last thing I'll say. I don't want to get too preachy about this, but I never exercised when I was young. I played sports when I was like in college and stuff, but then I stopped
I
exercising.
think that's called exercising.
Yeah, and then I stopped, right? And I think the reason I stopped is because there was nothing fun that I enjoyed. I hated going to the gym. I thought it was just boring as heck. And I hated running because same reason. And it was kind of painful. And it really took, for me personally, finding some sort of physical activity that I really, really love to do, to the point that I don't even realize I'm exercising when I'm doing it. And so I think that
I think this
I
is why
was
people
writing
end
this
up
paper,
playing
that
ultimate
would-
frisbee.
Yeah, play ultimate frisbee. Do something that you really love to do that you don't realize you're exercising by doing. I love to rock climb. People love different things. You got to find that thing for yourself and just build it into your life, because it will do way more than any of these medical treatments can possibly do for you. And I think with that, we should take questions.
All right.